So I'm going to talk to you a bit about trials and tribulations of assessing cardiovascular risk in 2013, partly going through our approach, but partly really trying to bring you up to date to where we think the field is, or at least where the field thinks it is. As we've talked before, and it's wonderful to see so many people who I've seen over the last few years, and really, again, thank you for coming. When we got into the space, I think a lot of our discussions with many people was, you know, there are a lot of markers out there, what's important, it's a bit confusing, and things of that nature. And we rapidly decided that you could, you know, bucket current testing into one of three buckets. One is really long-term risk. AHA-ACC guidelines tell us that we should be testing our patients in their early 20s. Patients who have an LDL of 450 at 22 years of age have a lifelong problem. And clearly a classic cholesterol panel is important. Then there's the midterm risk on the order of a decade or so, and that's really where advanced lipid testing comes in. What we're really looking for is which patients have normal LDLs but still a lot of high particles. It fundamentally comes down to the fact that we should really be measuring LDL based on ApoB. And I would suggest to you that any of the advanced cholesterol tests in the end are really giving you a measure of ApoB, high ApoB in those patients who have controlled cholesterol. And then there's really the near-term risk, which is really inflammation-based, which is obviously where we have focused, and Jake gave a great overview, and I'll go in a little bit deeper with that. But that is our really unique focus, our strategy, and what we believe we've brought to the marketplace, but most importantly, to practicing clinicians. We do also offer advanced lipid testing and obviously a classic lipid panel. Jake went over Dr. Ross's really seminal contributions in the mid-70s about the fact that atherosclerosis is a two-hit hypothesis. There has to be injury of the vessel wall, but ultimately then inflammation that follows that drives the atherosclerotic process. I would suggest to you that we as a field have spent almost 40 years focusing on the first leg of his hypothesis, that being the injury. And the injury being cholesterol mediated, most likely through the accumulation of low-density lipoprotein in the vessel wall, oxidation, injury of the endothelium, and the inflammation that ultimately follows that. And as Jake outlined, 50% of our patients who present with acute myocardial infarction or acute coronary syndrome these days actually have well-controlled lipids. And as I've now moved from an academic center to a high-volume community center, I would challenge that 50% to be much greater. There are people out in the community who are truly aggressively treating their lipids. Their lipids, in fact, are well-controlled, and yet they still present with acute coronary syndrome. So our belief is to make that next profound impact, and let me just take a step back to the injury part. We have decreased the number of ST elevation MIs, big MIs to the patients, by 70% in the last 20 years. There is no question we've been successful. The challenge is, as we've put that therapy out there, it no longer serves as a marker of true risk. So our belief to have that next profound impact on cardiovascular disease, to continue the mission that we've all been on for several decades, we need to turn to the second leg of Dr. Ross's hypothesis, which is inflammation. Probably the best proof of that study came out a few years ago, led by Paul Ritker, called the Jupiter trial. Paul, out of Brigham, really spent years bringing the concept of high-sensitivity CRP to clinical practice and really ran upstream to get people to understand the importance of inflammation and this marker. In Jupiter, as you may remember, these are patients who, by current guidelines, did not belong on statin or cholesterol-lowering therapy. Yet they had high-sensitivity CRPs above 2 milligrams per liter, and therefore were randomized to statin or placebo. This was a 5-year trial that was stopped in under 2 years due to excess benefit, and that benefit was life. And what you see in this slide is, if you treat a patient with a statin, in this case rosuvastatin, and you don't get their CRP down, and you don't get their lipids down, they in fact look like placebo. So we in fact can identify patients who are unresponsive or not gaining benefit to the therapy we're giving them, and as a practicing clinician, that's very important. What's also noted is if their LDL was lowered but not their CRP, they had benefit. If their CRP was lowered but not their LDL, they had benefit. But if their CRP and their LDL were lowered, they had yet greater benefit. So these data would suggest, and I think a lot of literature now demonstrates this, is if you choose to measure the lipid status of your patient or the inflammation status of the patient, you are agreeing to measure half the story. And you really are agreeing to miss or not risk stratify half the patient's risk. A recent study that's in press, accepted at Circulation by Steve Nichols, a former colleague at the clinic who's now back in Australia, demonstrates that in the Saturn trial, which was a high-dose statin trial of 40 milligrams of rosuvastatin or 80 milligrams of atorvastatin, looking at intravascular ultrasound at baseline and 2 years later, that only in those patients who had didn't increase their CRP or had a trend towards a decreased CRP was there evidence of plaque regression. All these patients had intravascular ultrasound measuring the amount of atheroma in their artery. And what this really interesting study shows is on-treatment CRP, in fact, predicted how the patient's plaque responded to statin therapy, but on-treatment LDL did not. So, in fact, further evidence that once the injury occurs, once the atherosclerosis has taken place, it's really important to minimize inflammation. And we'll get back to how we've done that through managing lipids. This is actually looking now at patient events. And what we see here is the lower the on-treatment CRP, the lower the event rate of stroke, death, non-fatal MI, and non-fatal stroke. So these are the hard endpoints that we all really care about in our patients, and quite frankly, our patients care about. And the reality is lowering their CRP now correlates not only with decreasing atheroma, but ultimately decreasing events. And if we look at hard endpoints and just general major adverse cardiac events, what you see here is, in fact, the change in CRP becomes statistically significant where the effects of LDL do not. So these are interesting data. The full paper will be out soon, but really demonstrates the importance of measuring inflammation in response to therapy in order to understand if we're truly impacting that patient, and also suggests that higher CRPs in our patients drive higher event rates. So as we entered the inflammation space with the Jupiter trial known and the basic biology that we understood for many of these markers, we developed the artery wall that Jake introduced, but a 6-marker panel that not only defined whether a given patient was at risk, but where that patient existed on a risk spectrum. So we have low-risk, really lifestyle markers like F2-isoprostane, OXLDL, all the way to evidence of disease, being high-sensitivity CRP and microalbuminuria, to evidence of very active disease like a myeloperoxidase and an LPPLA2 or a plaque. And I'm just going to take you briefly through each of these tests. F2-isoprostane is really a marker of lifestyle. If you get up like my daughter does at 6 in the morning and goes to yoga, if dinner isn't as my son does on the right, your F2-isoprostanes are pretty low. And what's exciting is many physicians have found they measure the inflammation panel. All markers are negative except the F2-isoprostane. They can turn to their patient and say, the good news is you don't have disease. The bad news is you're at risk of disease, and that risk is ultimately you. And it really gives us an objective measure of lifestyle risk. It allows us to track lifestyle risk and see if they're actually impacting things. Smoking, too, significantly raises F2-isoprostane. Going from a pure lifestyle risk to evidence of active disease, OXLDL is a strong marker of metabolic syndrome. Before the patient ultimately achieves metabolic syndrome, there was a recent study, which we'll discuss tomorrow a little bit more, where they looked at liver fat by ultrasound and found that overweight patients who had low liver fat content actually had very low risk. You can be a little overweight but not be at risk because you're physically fit. These data show that the higher the OXLDL, the higher the risk of developing metabolic syndrome in the ensuing years. LDL cholesterol did not predict the risk of metabolic syndrome. Here in the Indian atherosclerosis study, looking at hsCRP, which many of us have used because it marks obesity, and OXLDL was a much stronger predictor of the risk of developing metabolic syndrome than high-sensitivity CRP. Going from then lifestyle risk to really altered biology with oxidized ApoA1 or ApoB with OXLDL, we now go to markers of presence of risk. We've already talked about CRP. These are some of the more classic data from the Physicians' Health Study. 1,000 male physicians with no known history of cardiovascular disease enrolled in the trial, randomized to aspirin. And what we see here is the higher the hsCRP, the higher the risk of having a myocardial infarction. Just as important, the addition of aspirin significantly decreased the incidence rate in the high-risk patients, but it's also important in this era where we really look to markers to add therapy. We need to look to markers that actually suggest not adding therapy. For example, clearly the first quartile physicians, whether they had no benefit to aspirin. So we, in fact, can identify low-risk patients who we do not have to treat based on population statistics. Women are, it is true as well, the Women's Health Study, 28,000 women, no known coronary disease. If their CRP was low and their LDL was low, they did incredibly well. If their CRP or their LDLs were abnormal, they did worse. If their CRP and their LDL were high, they did yet worse. So again, this concept that if you choose to measure your lipid status or you choose to measure your patient's inflammation status, you're really choosing to identify half the risk. The HOPE trial for microalbuminuria, the amount of protein in the urine, demonstrated that the higher the proteinuria, the higher the risk of cardiovascular events. That didn't make a difference whether you were diabetic or non-diabetic. Protein in the urine is a marker of endothelial dysfunction, a marker of the presence of disease, and ultimately identifies patients with increased risk. Going from lifestyle to modified biology to evidence of disease, the question now becomes to what extent have we quiesced that disease? For this, we use two markers, a vulnerable plaque, and a myeloperoxidase, and an LPPLA2 or plaque test. Plaque looks under the vessel wall in the necrotic core. If it is quiesced and non-inflamed, LPPLA2 levels are very low. As we start to develop an active necrotic core, developing vulnerable plaque, chewing up that collagen cap, if you will, increasing the risk of an event, your LPPLA2 levels go up. Looking from the lumen where the blood is in the vessel, back at the vessel wall, if that is smooth, healthy, white cells pass right by, your myeloperoxidase levels are very low. However, if you have fissures, erosions, warming plaque, or vulnerable plaque forming, those white cells become activated against that vessel wall. They release myeloperoxidase into the bloodstream, and your cardio-MPO levels go up. So we're actually able to look then at two different markers from two different points of view to identify whether patients actually have active plaque. This is a study on LPPLA2 or plaque test. What we see here is stratified by CRP, basically stratified by the amount of atheroma. You can have very little atheroma with a low hsCRP, but a high plaque, and you can have a very significant 7 or 5% event rate for stroke. Go all the way to the right. Now you have a lot of atheroma. You have the same LPPLA2 level, but you have doubled that risk to 11%. So again, having active plaque significantly increases your risk of having disease and ultimately having a clinical event. This study in patients who had mild to moderate coronary disease by left heart catheterization, what we see here is that compared to the first tertile, the higher the MPO, the higher the risk of death over the ensuing decade. And what you'll appreciate if you look all the way to the left is these lines started to display fairly early. So evidence of vulnerable plaque, evidence of any single one of these markers really significantly suggests an increased risk of cardiovascular disease, but also cardiovascular events. What's the value of a multi-marker approach for further understanding our patients? Well, if we take that same data about left heart catheterizations of mild to moderate disease, and we looked at MPO, and the higher the MPO, the higher the risk, and we now stratify not just by MPO, but by hsCRP as well, what you'll appreciate is you can take a patient who even has coronary artery disease. If their MPO is low and their hsCRP is low, you in fact they do very well. They really don't die. They have very few events. However, if their MPO is high, active plaque, bad biology, or their CRP is high, a lot of atheroma, bad anatomy, they do worse. But they do yet worse if you have a lot of disease that's also very active. So you can really stratify your patient, determine even those who already have disease, how active is this patient, how well have I mitigated his or her risk, and how can I really work to further optimize their outcomes. We look at vulnerable plaque from 2 points of view because we want to look under the collagen cap and we want to look at the vessel surface. These data from a preventive cardiology clinic and an executive health clinic demonstrate the value of looking at both. If we look in this population at the vessel wall risk, really a high LPPLA2, an active necrotic core, we have about 5% of this population at risk. If we look at the white blood cell risk, the luminal risk, fissures, erosions, we have about 6% of the patients at risk. You have about 2,700 data points in front of you, yet only 6 patients have both markers up. Why is that? Well, if you have an active vessel wall that white cells are responding to, and it's in your coronary tree, you have acute coronary syndrome, and it's unlikely you're at your executive health appointment. You're likely in the emergency room somewhere. Thankfully, it's a rare event that we have both of these markers up. But ultimately, it identifies a patient population, those 6 patients, who really are at very high risk. They have vulnerable plaque that is ruptured somewhere in their body, whether it be in their legs for peripheral arterial disease, their belly for aneurysms, their necks for stroke risk. They're actually a very high-risk population. And we need to treat those patients, and those ultimately are the patients who really need a pan-vascular assessment. It's not everybody that needs these things, but again, a very low number, but a very important number of patients. So anatomy is important. Biological risk assessment is important, and it turns out that they're synergistic. Anatomy is hard to follow. You can look at the carotids of your patient, and you can be 48 and have carotids of a 60-year-old. It's unlikely those carotids will ever be less than a 60-year-old, but hopefully when you're 60, that 48-year-old will catch up to their carotids. So you can't really assess whether your treatment strategy is truly helping them or not. Biology is important and can be followed. You can follow our markers, and you can see them come down. They will modulate to treatment strategy. And it turns out there's additive risk stratification. This is a study of calcium scoring where they measured MPO levels. The higher the calcium score, the higher the MPO level. More calcium, the higher your risk of having vulnerable plaque. That makes sense. And they, as we and others have shown, the higher the myeloperoxidase, the higher the risk of events. But if we start stratifying by MPO, the biological marker, if you have a low MPO, good biology, but bad anatomy with a high calcium score, you actually have a risk of about 7% in this study. If you have bad biology, active vulnerable plaque, and you have a high calcium score, you've actually doubled that risk to about 14%. So it's just like the CRP plaque data I showed you. Here's calcium scoring MPO data. The reality is understanding the biology and assessing anatomy are synergistic and additive. They're not duplicative and offer us a greater insight to our patient's risk. And it's true here for peripheral arterial disease, looking at patients with cardiovascular risk. We can look at good biology, a low MPO, and they do better than a bad biology with a high MPO. But when we start stratifying by biology and anatomy, good ankle-brachial index, we've revascularized the legs, and good biology with a low MPO, they virtually have no events. If we have bad biology with a high MPO, bad anatomy with a low ABI, they do worse. And yet worse, a low ABI, bad flow, and a high MPO, these patients have much greater risk. So as a practicing clinician, where does this really impact us? And Jake talked about the executive, physical, and employer understanding of their employee risk. From my point of view, it's about my patient's risk and my patients who are under my care. I always go back to this case. It was one of my earlier cases when I was running the coronary intensive care unit at the clinic. He was a 33-year-old male, thin smoker with 3 days of intermittent non-muscular ache. Classic to most 33-year-olds, can't be a heart attack, I'm too young. One day of constant chest pain led him to come to the emergency room. At 8 o'clock, he was EMS to the house. He was taken to an outside hospital, given lytics. This was back in 2001. He failed lytic therapy, transferred to the clinic for rescue stenting around midnight. You may not appreciate this. I don't know how it projects. I don't think I have a pointer here, but if the upper left, his left anterior descending is completely closed, you can't see it because it's gone. But the point is, this is a widowmaker lesion, right? And widowmaker for a good reason, although he wasn't married. These people lived now. Importantly, if they make it to the hospital, they really do live these days. And that's a whole different story, but a very important one. So he ended up with left heart catheterization at a proximal AD occlusion, which was stented. He was transferred to the coronary intensive care unit in cardiogenic shock. And we worked on him for 9 days with pumps and all the other fun things we can do. And ultimately weaned him to oral therapy and transferred out to the coronary intensive care unit 9 days later. The good news is he was a 33-year-old male with an LDL of 98, an HDL of 48, and triglycerides of 86, and this was before his heart attack. The bad news is, who cares about the good news? He's got severe LV dysfunction. He's at incredibly high risk of heart failure, and he already has class 3 heart failure on the floor. So, sure, we worked for 9 days and we saved his life, and that's great. We failed him because we didn't identify a patient who clearly had increased cardiovascular risk. And ultimately, he's still alive, I know that. And he still has his own heart, importantly. But nonetheless is not going to have a very long-term good outcome. So what do we really do, and how do I find this valuable? Just going back to the Country Radio Symposium, and this is true for those cardiologists and internists and family practice folks in the audience. This is true for all of us. We'll see our 531 patients, and these folks were not unlike many of the patients I see often in Akron. Who do I have to worry about? I can't do everything for everybody. I don't have the time and I don't have the money. And I don't have the desire because I don't think there's a need. There was a day, as we all remember, that we stress tested all our patients. That didn't make a lot of sense and still doesn't. But, again, a population of patients who aren't unlike the population that all of us see every day, good. So I can find my 121 patients out of 531 who ultimately have abnormal cholesterol level, and shame on me that I haven't treated it already, but we can get that down. And in this study, we called an abnormal cholesterol greater than 130. Depending on, obviously, risk profiles, that should be less than 100, and more patients perhaps would be at risk. But if we focus on the folks who, if I just looked at lipids in my clinic, I would completely miss. 135 of those 531 actually had high hsCRPs. And let me also go back and make the point. 40%, 45% of these patients had all the markers normal. So we're not identifying risk in everybody, and that's really what our MDVIP publication showed. But 135 of my patients would ultimately have high hsCRPs, hardening of the arteries, and based on Paul Ritker's work and some of our work, they should be assessed if not treated. But most importantly, 13 of the patients had increased or evidence of active plaque by a high MPO or a high Lp(a)2. 24 of those patients had a high CRP, a lot of atheroma, the HeartLab study showing high MPO and high CRP being at increased risk. And a single patient had a high MPO and a high plaque, truly the highest risk patient we can identify in our population. So I can take my 531 patients, and I can, in fact, tell myself which 38 I have to care about now, which 135, or actually it turns out to be 106, that I should worry about in time and not forget about, and which 45%, a couple hundred patients, I can, pat on the back, say, you're doing okay, and I'll see you next year. And to me, that's incredibly valuable to be able to identify those patients who the resources are necessary, the outcomes can be changed, and the time is well spent because we're going to truly have a significant impact. We all know about number needed to treat for a given drug, and we look at that number needed to treat to decide if treating is worthwhile. We can actually improve that specificity of who can ultimately benefit. So where's the disconnect? We have spent 30 years measuring lipids, treating lipids, and yet we're now at a point where half our patients have good lipids and have events. What we forget, or what we've learned, most importantly, is that when we use HMG-CoA reductase inhibitors, we're blocking a significant number of biological pathways. We're blocking cholesterol synthesis. That's ultimately what we're trying to do here. But we're also blocking adrenal granulation. And that drives RAC and ROS signaling, which ultimately drives NADPH oxidase and superoxide generation. What we need to understand is that statin therapy is a very potent anti-inflammatory. And we, in fact, have been treating inflammation alongside of lipids. And this is actually not a long deviation from what we've already been doing. And it's part of the reason why the Saturn trial showed many patients decreasing CRPs. There's a reason for this. When we look at superoxide, O2 dot minus, upper left next to leukocyte there, it is required for myeloperoxidase-mediated inflammation, nitric oxide synthase-mediated inflammation, ceruloplasmin-mediated inflammation, and metal ion-mediated inflammation. So in fact, by blocking superoxide with statins, we are blocking a significant driver of leukocyte-generated oxidants. Udit Agarwal, a graduate student of mine a few years ago, did a very detailed study in mice, which I'm not going to take you through, although I'm happy to talk about it, that ultimately showed that whether you knock out myeloperoxidase, you knock out nitric oxide synthase, you knock out ceruloplasmin, the only thing that ultimately is required is knocking out superoxide. Because if you knock out MPO, the superoxide goes through nitric oxide synthase. You knock out the nitric oxide synthase, it goes through MPO. It's superoxide that drives it all. And we have to remember that statin therapy blocks superoxide, and we've shown that in other studies in clinical populations as well. So in fact, there is no disconnect. We have been treating inflammation and oxidation from 1994 on when the 4S trial came out with simvastatin. And what we now need to understand is that we need to measure that second half of what lipid-lowering therapy affects, inflammation, so that we can actually determine if we have fully mitigated risk in patients. And so this is the part that I think we really need to come to understand. Our markers have helped us understand this. The biology that we and many have uncovered has also helped us understand this. So in summary, it's clear that inflammation is the operative mechanism of adverse events in patients with atherosclerosis. You can have a lot of cholesterol running around. You're not going to have an event unless you have inflammation in your artery wall. There's growing evidence that monitoring inflammatory markers identifies patients at risk and, most importantly, identifies patients' response to treatment as well. Understand the physiology represented by a marker not only identifies patients at risk, but it really defines where they are on that spectrum of risk. I would much rather have a high OXLDL than a high MPO and a high plaque. But yet both those patients are ultimately at risk for cardiovascular disease. Our approach, our need, our education ultimately has to be determined or based on where that patient exists on a spectrum. And our patients, quite frankly, like being treated as individuals. And multi-marker inflammation approach allows identification of graded risk within a population. So whether you're an employer looking for what your overall risks are or which patients I really need to incentivize to become healthy, or you're a doc trying to figure out who in your clinical population or your clinical panel needs aggressive care, knowing where they are on that risk spectrum is ultimately incredibly valuable. So once again, I thank you all for being here. Look forward to a great 2 days, and I'm happy to answer any questions during the panel later. Thank you.